Welcome back. Let's walk through a realistic scenario to apply what we've learned. Here we have a 28-year-old man in a park acting bizarrely and aggressively. It's a warm evening, he's shirtless and sweating. Already you might suspect hyperthermia or stimulant use. He's yelling nonsense, which indicates altered mental status, likely delirium. He's extremely agitated, even combative. He is punching a trash can. When engaged, he's paranoid. They're trying to kill me. A possible hallucination or delusion. He injures himself, cuts his head, but doesn't react normally to pain, a classic sign that something is off neurologically, possibly agitated delirium or drug influence. As EMS and police, we attempt verbal de escalation first. The cops arrive and try to calm him verbally, but he charges at an officer, clearly a threat. At that point, the hands on decision is made. Multiple responders tackle and restrain him, which is done with difficulty given his strength. It takes 5 people, aligning with the recommended team approach for safety. You successfully get 4-point restraints on him on the stretcher, but note he's still struggling violently. His skin is very hot, confirms your suspicion of hyperthermia. Bystander info suggests bath salts, a stimulant drug, which fits with this agitated delirium picture. He's showing all the signs: extreme agitation, superhuman strength, imperviousness to pain, likely hyperthermic, delirious. Now, the question for you as the EMS team is, what are your next steps? We have the patient physically restrained, but he's far from safe. He's essentially a textbook agitated delirium case, at high risk for sudden cardiac arrest if we don't manage him quickly. Let's think through it. Ensure continued safety. We have him strapped, but still thrashing. Make sure no one gets in harm's way of his head. He's trying to bite. Possibly consider putting a soft cervical collar not for C-spine, but to prevent biting, spitting, or have someone control the head. Watch that his airway isn't obstructed while he's prone on the ground. Ideally, get him supine on the stretcher quickly. Call for ALS if not on scene. If a paramedic unit isn't there yet, this is the moment you're asking on the radio for one. In our scenario, let's assume either you already had a paramedic with you, you are a paramedic, or you requested one with the initial dispatch. Sedation. This patient absolutely needs chemical restraint. He is the definition of cannot be safely managed by physical restraint alone. You'd likely draw up ketamine IM if you are the paramedic, or have your paramedic draw it up if not, as it's a fast and appropriate choice for suspected excited delirium due to a stimulant. While one provider is doing that, others continue to physically secure the patient. Monitoring and initial medical care. As soon as possible, check vital signs, at least a pulse and respirations. He's probably tachycardic, let's say pulse 150, and hypertensive when we measure BP. If you can get a quick tympanic temperature, do so. If not, you know he's hot. Start cooling measures right away. Have someone fetch water or saline to douse skin, or place cold packs in armpits and groin if available. Begin high-flow O2. Even if he's thrashing, try to hold a non-rebreather near his face or a nasal cannula in if you can do it safely. This helps with any hypoxia and prepares for sedation. When able, place an end-tidal nasal cannula to get a CO2 reading. The scenario leaves us at a decision point, which is what the next slide will resolve. Given the case, you likely answered mentally, administer sedative, ketamine IM, and begin treating hyperthermia and any reversible causes, then transport emergently. Let's see how this plays out and what lessons it illustrates. In our scenario, let's say you, if a paramedic, or the ALS crew on scene quickly draws up ketamine and injects it into a large muscle, thigh, or shoulder, while the team maintains holds. Within about 2 minutes, the ketamine takes effect. The patient's thrashing diminishes and he enters a dissociative, calmer state. We're able to safely turn him supine on the stretcher and secure him with straps in a proper position. We remove the rest of his clothing to help cool him, and because clothing was torn or sweaty anyway. We cover his lower body with a light sheet for dignity, while still promoting cooling by leaving the torso exposed. We put him on 15 liters of oxygen by non-rebreather. We also attach monitors. His heart rate is around 160, blood pressure is 180 over 100, respiration's 30 but starting to slow now with sedation. We managed to get a blood glucose reading which is 122, normal, so not hypoglycemic, good to check off. Pupils are dilated. The ECG shows sinus tachycardia, fast heart rhythm, but no obvious ST changes or dysrhythmias at the moment. We continue cooling measures with some cold packs and by fanning the patient. All of this is done rapidly as we load and go. This patient needs to be in an ER, so we start transport as soon as he's sedated and restrained properly. During transport, despite everything, the patient's condition takes a sudden turn. A few minutes in, you notice he's no longer moving at all, which isn't surprising after ketamine, but then you check and he has no pulse. He's gone into cardiac arrest, specifically pulseless electrical activity, PEA, on the monitor. Immediately, your team starts CPR, ventilate him, and follow ACLS guidelines, CPR, fluids, epinephrine, etc. You radio ahead to the hospital that you have a cardiac arrest due to excited delirium. After around 10 to 15 minutes of resuscitation, you arrive at the ER. The hospital team continues aggressive efforts for another 20 to 25 minutes, but sadly, there's no ROSC, return of spontaneous circulation. The patient is pronounced dead at the hospital. This outcome is tragic, but unfortunately not unprecedented in excited delirium cases. We did a lot of things right here. We ensured scene safety, we sedated as early as possible, we cooled the patient, gave oxygen, etc. Sometimes, despite our best efforts, the physiologic train had already left the station, so to speak. The metabolic acidosis, hyperthermia, and catecholamine overload might have been too severe. It underscores that even with proper management, these patients are at grave risk. It is important to note this patient died from a complicated physiologic process, but it was not due to the use of ketamine as long as the patient was positioned appropriately. An autopsy in such a case might show no obvious cause of death, like in many excited delirium cases. Often they'll attribute it to complications of drug-induced agitated delirium, or similar. In this scenario, maybe the toxicology comes back showing high levels of a stimulant, like methamphetamine or bath salts, and the death is deemed due to the drug's effects causing a hyperadrenergic state and cardiac arrest. There might also be evidence of rhabdomyolysis and an acidotic pH on blood labs drawn. Now, not all cases end in death. Many patients do survive with prompt sedation and care, but I presented a worst-case outcome to highlight how serious this syndrome is. In other instances, if we manage to sedate early and support them, the patient might cool down, stabilize, and later regain alertness in the ER, perhaps with no memory of what happened. Those are the ones where EMS truly made the difference preventing a death. Let's extract the lessons. We followed the proper steps: safety, teamwork and restraint, early ALS and sedation, aggressive medical treatment, and rapid transport. Even though the outcome was poor here, those steps are our best chance at a good outcome. If we had done any less, say, delayed sedation or struggled longer physically, the outcome could have been the same or worse, potentially injuring providers too. This scenario reinforces why excited delirium or agitated delirium calls for quick, decisive EMS action and why they are so challenging. It's also a reminder of the toll it can take, which is why debriefing and support for the crew after such an event is important. In conclusion, managing violent agitation and excited delirium in the field is about balancing safety and compassionate care under pressure. Let's recap the key points from our presentation. Scene safety is always number one. You can't help the patient if you or your partners get injured. Use law enforcement and extra help, have a plan, and secure the scene before hands-on care. Work as a team. These events demand coordination and communication. Your first priority is to protect everyone from harm, including the patient. Recognize that a violently agitated patient is likely experiencing a medical emergency. Whether it's drugs, a psychiatric crisis, or a medical condition like hypoxia or hypoglycemia, something is driving that behavior. Identify and treat reversible causes whenever possible. Give oxygen, check glucose, consider naloxone if opioid overdose is suspected. Though opioids typically cause sedation, not agitation, but mixed intoxications happen. If the patient is hot, start cooling. If they're postictal, be prepared for recurrent seizure. Viewing the situation through a medical lens helps guide your actions and reminds you this is a patient in need, not just a threat or bad guy. Start with verbal de-escalation and the least forceful interventions, but be ready to act quickly if the situation deteriorates. Your goal is to calm the patient, but if they remain a danger, don't delay physical restraint or chemical sedation when indicated. Time is critical in excited delirium. Prolonged struggling can kill the patient. It's a fine line. You want to be patient and calm, but also decisive when it's clear that talk isn't working. Practice and training help you know when that moment is. Once you decide, commit to the plan with your team and get control rapidly. Use proper and current practices. Terminology aside, follow your guidelines, which are likely based on the latest evidence. Avoid outdated concepts or methods that are no longer supported. For instance, as we discussed, the term excited delirium itself is on its way out in medicine, but the phenomenon of severe agitated delirium is real. Treat it seriously, just frame it correctly. Also, use approved restraint techniques, no hog tying, no prone pressure, etc., and appropriate sedative medications per medical direction. Stay within your scope. For EMTs, that means facilitating ALS care when needed. Maintain the patient's humanity throughout. This patient might be spitting, cursing, or swinging at you now, but remember they are a person who will hopefully recover and have to live with how they were treated. Treat them with dignity and respect. Speak to them kindly before, during, and after the restraint. Explain what's happening. Once they're calm, reassure them. And absolutely keep monitoring them like any other critical patient: airway, breathing, circulation, level of consciousness. It's even more crucial after you've sedated or restrained someone. Many excited delirium deaths have occurred because a patient was restrained and then not properly observed. We must not let that happen. If you restrain someone, you own their well being from that point until you hand off to the ED. That means constant vigilance. Finally, ensure a safe handoff to the emergency department team. Give a thorough report, including what the presumed cause is, what struggles and drugs were involved, and any injuries or concerns, like he had a head laceration, we started cooling, he received 5 milligrams per kilogram ketamine IM, now he's calm but intubated, etc. This helps the hospital continue appropriate care, like aggressive cooling, sedation, or treatment of acidosis. Violent and delirious patients present some of the most complex challenges in EMS. But with knowledge, teamwork, and practice, you can manage these situations effectively. Always prioritize safety, act within protocol, and treat the patient as you'd want yourself or a loved one treated in a medical crisis. By doing so, you maximize the chances of a safe outcome for everyone. Thank you for your attention. Stay safe out there, and remember that calm, confident, and compassionate care is the goal, even in the most chaotic of scenes.